Welcome all doctors. How are you? Good afternoon. Today, this is a meeting with you doctors. You are planning for MRCOG Part 3 exam, mostly in November, inshallah. But it's informative even for doctors planning for later exams of Part 3. At first, let me introduce myself. I am Dr. OSAMA AKL, one of the RCOG examiners, and I am trainer in London Center. And also I am trainer in Egypt Center. Okay, and at first, let me congratulate all doctors who passed last MRCOG Part 2 exam recently within the last week. Congratulations and best wishes for the next step. And the good news that you passed already the most difficult and the most challenging part in MRCOG, which is MRCOG Part 2. And we are expecting that after passing Part 2, already you have very good amount of knowledge, which will help you much, inshallah, in Part 3. So in Part 3, we will be targeted towards other skills that you need to have. Already, you have the knowledge. Some doctors may say, Doctor, I passed Part 2, but I am not sure, not very sure of my knowledge yet. No problem. There is studying for Part 3 exam, which will help you to again gain confidence and to be sure that you have good amount of knowledge. What do you mean? I am talking about what's called patient information leaflets. I will tell you how to reach them and how to study them. Welcome, Dr. Sarah. How are you? So, Alhamdulillah, you passed Part 1, you passed Part 2, and you are now going to have the last step, which is Part 3 exam. And as we said, the Part 2 is the most challenging. Part 3 is somehow easier. When you are preparing for Part 3, I want you to assume that you are doing training, that you are going to participate in a play, in a movie, and you are an actor. It's exactly like that. If you train well, okay, and you are trained well to play this role, inshallah, you will pass this exam. So we can see you later in the ceremony, receiving the certificate in London, inshallah. I know how much you worked to pass Part 2 exam. Inshallah, Part 3, I think it will be more interesting because it's not a matter of reading, it's a matter of practicing. So reading is not the most important thing for Part 3 at all. Part 3, as we said, okay, you are having training to play well this role. This is what you should plan to do. So what is Part 3 and what are the advantages and disadvantages of Part 3 exam? Let's start with the good news first. Then we will see what are the challenges and how we can overcome these challenges. At first, Part 3 exam. It's same like what you do in your clinic, in your hospital. You are meeting the patient, you are talking to the patient in the lay language without using any difficult medical terms. This is the same what you are asked to do in the exam. And it's something very nice that when you are having training for Part 3 exam, when you go to your clinic, you apply what you learn in the clinic directly. This will help you. So in the exam, you are behaving by your nature, not assuming something, not just playing a role. So it's your usual daily work. Talking with the patient, using simple language, feeling always sympathy to the patient, dealing with the patient nicely. The technique, when you learn it well, you can pass, inshallah, in the exam. So as we said, it's not a matter of studying, it's a matter of skills you need to gain, and it's a matter of practice and techniques and skills you should perform. Don't worry, all this, inshallah, we will talk about it and how to plan for it. Also, the good news, now you have the enough knowledge to pass Part 3 exam. What is remaining? The skills and the techniques. Okay, so the challenges in Part 3 exam will be, number one, you are against the time because you have to complete the station in 12 minutes. In the exam, we have 14 stations. Every station takes 12 minutes. These 12 minutes, 2 minutes of them, you are reading the scenario and preparing yourself, and 10 minutes, you are performing what you should do. Until the current moment, okay, our knowledge about the next exam in November, will it be face-to-face or online? Because the last exams in February and also May exam were online exams, not face-to-face, except in London. But the coming exam in Egypt, it will be face-to-face. So doctors present in Egypt, they can have the exam in November, inshallah, in Cairo, face-to-face, physical attendance. What about other centers? We don't have enough knowledge about it so far. But in Egypt, in November, it will be face-to-face exam. And already in London, in the last exams, it was already face-to-face exam. Until the current moment, there is not enough data about the coming centers on MRCOG website. So the good news, already you have the knowledge. What is remaining? Skills and techniques. So what are the difficulties if the exam became in all centers face-to-face? If you ask me personally, okay, if I were a candidate preparing for Part 3 exam, I would like more online exams because already you are at home or at your clinic or at your office, okay, without the need to travel and to bear the cost of traveling and the cost of booking for a hotel and so on. Okay, so this is a challenge. If the exam will be face-to-face in all centers, cost is a challenge because you may need to travel, you may need to book a hotel. Okay, so this is extra cost. Another challenge in Part 3 that it's made of 4 trials only. If you remember in Part 2 exam, the number of trials was unlimited. In Part 3, you should pass within 4 trials. What if doctors couldn't pass the exam in 4 trials? Unfortunately, they will need to have MRCOG Part 2 exam again. Inshallah, most of you will pass mainly in the first trial, inshallah. So this number of trials, it's a challenge and it's a psychological load upon you while you are preparing for the exam. My voice is okay, right? So these are the challenges in Part 3 exam. As you see, the good news and the easy things are more than the challenges. Okay, according to MRCOG website, by 8th of August, which is tomorrow, you should have done 2 things. Number 1, confirm that your address on your account is written clearly and it's in the country where you are planning to have the exam. For example, I will have the exam in Egypt. Okay, I will write that I am in Egypt. Why? If your country of residence and your address on your account on MRCOG website is the same like the country that will hold the exam, one of the centers, for example, Egypt, you have the priority. So if I am a doctor living in Sudan and I want to book for the exam in Egypt center, Egyptian doctors, they have the priority. After Egyptian doctors book for the exam, other doctors can book later. As you see here, there is difference between doctors having the priority. They are the doctors living in the same country, like the exam center. After they book, then other doctors can book for the exam. So doctors living in the same country as the country having the exam center, they have the priority to book for the exam. Okay, so by tomorrow, as we said, 2 things you should have done. Number 1, you revised your email address, you revised your living address in your account in MRCOG website. Number 2, you should confirm that you sent assessment of training. If you do already assessment of training before Part 2 exam, you don't need to do it again. So you need this assessment once in your life. Some doctors already did it before Part 2, okay. you don't need to do it again. If you didn't do it before part 2, you have to do it today, maximum tomorrow. Try to do it today, please. After that, to be confirmed, they will send here later what is the time that we can have token emails to book for the exam. Then the priority doctors will book for the exam. Then other doctors will book. Then booking will close. And then the result, inshallah, will be released about 4 to 5 weeks after the exam. Anybody here, can you write please on the chat? Anybody here didn't do assessment of training yet? Yes or no? Did you do it? Did you do it? Yes or no? You are planning for November, Dr. Shazia and Dr. Sarah? Okay, let's see how we can do the assessment of training. Okay, Dr. Dua, at least you sent. Okay, it's very good. Even if you didn't receive its result yet, but at least you sent. Okay, so you did what you should do. It's very good. Okay. Okay, Dr. Haneen, please, you can open your mic and ask. And please, other doctors, keep your mic closed. Yes, Dr. Haneen, please ask. You can have the mic. You want the mic? Okay. So what is your question about? As we said, for example, I am an Egyptian doctor. I will confirm that my address written in my account, it's my address in Egypt. So I can have a priority, okay, when I'm going to book in Egypt Center, inshallah. Yes, you can. Yes, you can. You can change your address today, no problem. Okay, change later. You cannot change the address later. Today is the last day to change your address. Okay. Okay. So how the assessment of training looks like? This is the form here. You can download it from MRCOG website. And already I did before a video about how to write it. It's present on YouTube in Arabic. Okay, here you need to write your name and your college ID number, your gender, and your date of birth. And here you will write your medical qualification from which school and in which year you were qualified as a medical doctor. And here, if you are working in UK, you need to write your GMC number. Most of you here are not working already in UK. That's why most of you are not route A. Most of you are route B, that you are a doctor from outside UK and you want to have the exam. Dr. Soma is asking how to change the address. Open MRCOG website, log in with your account, then search for details. Press details, you will find your address. You can change it. Dr. Noah asking about online exam. Are they 4 or 5 trials? Physical exam, 4 trials, for sure. While online, because they were trying the online regimen, okay, so the previous trials, they said the doctor, if you are having, this is your first trial, it will not be counted. But physical attendance, total 4 trials. Again, physical attendance, total 4 trials. Okay, Dr. Hussam, if you are working in UK, you can write your GMC registration number here and write your date of entry into registry. Thanks much, Dr. Sana. This time, no online exam. At least in Egypt, there is no online. About other centers, there is no data yet on MRCOG website. That's why today I will explain the two methods together, physical attendance and online exam. until May 2022, the exam in Egypt was online. Starting from November, there is no online in Egypt because already the college is preferring face-to-face exams more than online. There will be no online in Egypt in November. Okay, here you press if you are registered already into UK specialist training program and you are having a training number, you will enter your training number here. Otherwise, you will press route B, like doctors working outside UK. If you are MTI, you will also press here. Thank you. So here in these tables, we have one table here above and one table below. The one table above, you will write your general training. All of us had training when we were undergraduate about internal medicine, surgery, ENT, ophthalmology, anesthesia, and others, emergency. You will write here your general training. For example, ophthalmology, 2 months from to in which hospital, what was the name of the consultant, and you will include a certificate about your training in Egyptian method. It's الامتياز. So سنة الامتياز, you will attach it. Okay, the 1 year of training before you start to practice medicine. You will write, for example, here internal medicine, ophthalmology, surgery. Don't write gynae ops. Okay, so you will write here these other specialties other than gynae and ops that you were trained for, okay, when you were undergraduates. Dr. Hussam asking, can I apply for Egyptian exam? Yes, why not? You can change your address to be your address in Egypt. So you can book in Egypt and you can have the priority in Egypt. Okay, and if you are already now in UK, you can keep the address as it is in UK and you can have the exam in UK. Okay, but if you ask me, if I have two possibilities, to have the exam in London or to have the exam in Egypt, I prefer having the exam in Egypt. Why? In UK, the challenge is somehow more difficult because, for example, I had my Part 3 exam in London. The challenge was strong because you are having a challenge with UK candidates, okay, and with British doctors. The challenge is more than other countries. Okay, so here you will write your general training, and here you will write your work as a gynecologist and obstetrician. For example, I worked as a resident from specific date to specific date in which hospital, what was the name of the consultant in charge, and I will attach the experience certificate from this hospital. So if I work it, for example, because we need 4 years experience in gynae and ops, 4 years. And these 4 years, okay, should end within the last 2 years. For example, I will write that I worked as a gynae and ops specialist, gynae and ops, okay, 5 years, they need 4 at least. Okay, from, for example, March 2016 to March 2021. Hospital, for example, any general hospital, my consultant was so and so, and I have to get a certificate from this hospital confirming that I work at this duration in this hospital, because I will attach it in this email as an attachment. Clear so far? Clear so far? We need at least 4 years. Notice that any hospital, you will write its name here, you will get certificate from it. That's why if you can have training, recent one, at least 4 years in one hospital, it will be enough because you can now attach one certificate. Okay. Then you will write your signature and write the date, and you will attach this form with the form you will get from your hospital. Okay, we want a hospital that has gynae and ops wards, not just outpatient clinic. We need hospital, whatever this hospital is, general or private. Okay, and we will write in the form that, for example, hospital so and so, to whom it may concern, we confirm that doctor so and so worked in our hospital as a gynecology and obstetric specialist from specific date to specific date, working full-time, gynae, ops, and family planning. Finished. Don't forget, in this form, it's very important to put the theme, the logo of the hospital, and its address, and its telephone number. So if the college wants to call them, the college can do so. Okay. So you have to attach your medical registration certificate and certificate confirming your training, okay, which is the year of being house officer. You have to attach a certificate, okay, and the certificate from your hospital. So medical registration, certificate confirming you worked as gynecology and obstetrician, and certificate of undergraduate training, okay, of emergency, internal medicine, surgery, ophthalmology, and others. Okay, and all of them will be in one email, and you will send it as an attachment to this email address, including this form, your medical registration form, and the form confirming your training in other specialties as undergraduate, and the form of your current hospital confirming that you are working as gynae and ops at least 4 years. Clear? Any question about how to do assessment of training form? Okay. According to the timetable, the last day for assessment of training application is Monday, which is tomorrow. Clear so far? Somebody wants to ask on the mic? So this is how to do the assessment of training, and you will find another video explaining the same procedure in Arabic on YouTube. Okay. So again, by tomorrow, you should have sent assessment of training and confirm that you are writing your address in a good way in your account in MRCOG website. Dr. Nesreen asking if I change my address to other country to able to get exam, should I have to do this? Yes, for example, if you write that you are living in Egypt and you booked in Egypt, you have a priority. What if that your address now you are in Saudi Arabia and you wanted to book in Egypt? You are not among the priority group. You are like general eligible group. So you will not book with this group. The priority, and you will book with this group. Clear? Here priority, and then after a few days, other eligible doctors will be able to book. Who have the priority? Doctors whom their address is the same like the country having as a center. I did assessment of training. Okay, it's valid. You don't need to make it anymore. It's once in life. Once in life. Online exam, Dr. Nesreen, the same. If I am in Emirates, and in Emirates, there will be online exam, and my address that I am in Emirates, okay, I have a priority. Same like physical exam. Doctors in the same country having the center, they have the priority. It's like a thank you word from the MRCOG to the country holding the exam. That doctors present in this country, they have more priority. Okay? Okay. So here in this link, about assessment of training, you can download the assessment of training form and fill it. AOT applicants close on Monday, 8 August. So try to do it today as much as you can. Okay. What is the exam format? I will start by the physical attendance exam, face-to-face exam. Face-to-face exam is made of 14 stations, and every station of them made of 12 minutes. These 12 minutes, you have 2 minutes to read the question and prepare yourself. Okay, then 10 minutes to perform inside the cubicle. This place is called the cubicle. If you find here, I am now a doctor having my exam in circuit B. In circuit B, you will find cubicle 1, cubicle 2, cubicle 3, 4, 5, 6, until 14. Okay, so I am Osama. I will start at cubicle number 4. And at the end of the exam, I will be at cubicle number 3. So I had the 14 stations. Another doctor will start at cubicle number 5. At the end of the exam, his last station will be station number 4. Another doctor will start as number 1. And at the end of the exam, he will be at number 14. Clear this idea? What we will find inside these cubicles? Here outside, you will find a paper. This paper containing your question. For example, you are ST5, you are going to meet Mrs. Sarah Muhammad. She is a patient with diabetes and planning for pregnancy. Please counsel her. The domains you are going to cover, so and so. 2 minutes. At the end of the 2 minutes, the ring will buzzer. So you enter inside the buzzer will ring. So you enter inside the cubicle and you will find there the examiner and you will find the role player sitting beside the examiner. So you will start to contact the role player immediately who is acting as if she is a patient. Okay, so this is the appearance of the scene of the exam in physical live attendance face-to-face exam. In these cubicles, the scenario can be either one of the coming scenarios. Either inside the cubicle, you are going to find only one person. Who is this one person? The examiner. Or you may find 2 persons. So one of them, examiner, and the other one, role player. Or you may find 3 people in front of you. One of them, the examiner, another one, role player, another one called lay examiner. Another examiner, but lay examiner is not a doctor. What do you mean lay examiner? This is one of the government or one of the society coming to assess the exam. Lay examiner will give you a score, not about your knowledge, because she is not a doctor. She will give you a score about your dealing and your communication with the patient. Okay? Okay. So either you will find examiner only, one person. So this examiner will ask you some questions. Or examiner and role player. So the role player, you will start immediately after entering inside the cubicle, you will start to contact her immediately. And please don't care at all about the examiner. If you find 2 people, so one the examiner, one the role player, don't communicate at all with the examiner. Even don't say hello or good morning to the examiner. Start talking immediately to the patient, because now as if exactly you are inside the clinic, not in the exam. And also don't communicate with the examiner. Okay. What if I find only examiner? So this exam is called structured discussion station. In a structured discussion, the examiner will ask you some questions. Okay, here you can say, hello, sir, sit down and say, I am ready. Don't say your name. Don't say your name. Just hello, sir, and sit down. If it's structured discussion between you, the examiner. If it's role player task, communicate with the role player. Don't communicate with the examiner. Okay. And already during reading the scenario outside the cubicle, you will know, is it structured discussion or role player task? And it's already written on the paper outside here. It's written if this is structured discussion or role player task. Dr. Hussam asking, there are two options for the address to be active. Yes, activate the one that you want to use in the exam. Activate the one that you want to use for the exam. You can have more than one address, okay? But today, activate the one that you want to use in this exam. Okay. So this is a physical attendance, the physical attendance exam. You go to a center to have the exam. For example, you will know that the exam is present in Egypt in a specific hotel or in a specific center. You will go before the time and you are ready, so you can receive your ticket, okay? And they should see your visa, or they should see your passport, or your national ID to confirm your identity. Then you will start to have the exam at the exact time. The exam is total 168 minutes. 168 minutes without a break. There is no any break, so you have to enter the toilet before starting the exam. There is no time for the toilet. There is water, but toilet no. And this was one of the advantages in online exam. Okay, that there was a break in the middle, few minutes in the middle between the first 7 stations and the next 7 stations. This does not exist anymore here in physical attendance exam. They may change it. They may add a small break in between, but I don't think that. Because to give a break and again rearrange the doctors, it will be very difficult. So mostly it will be again 168 minutes without any break in between. Okay. Inside the cubicle, you have to concentrate very well with the examiner and with the role player, if it's a role player task. Because in the physical attendance exam, you can find some noise around you from other doctors in the neighbor cubicles. So concentrate and delete any background noise from your mind. Just concentrate with the patient, with the role player. When the exam was online, we don't know if there will be online exams anymore. You are having the exam from home or your office, from any place, okay, that is well equipped with good internet and with good computer, okay? You find in front of you the role player, okay, and here you find the examiner. It was on a computer program on the website called Osler. Okay, this was a computer program, okay, that managed the online exams. Okay, okay, and online exam, we do marking on the mark sheet during your speaking. So after finishing the 10 minutes, we have 2 minutes to fill this sheet to give you a score. In every item, because you have 5 domains, in some stations you need 4, some stations you need 3. For example, we have 5 domains required from you. Okay, 1, 2, 3, 4, 5. In every one of them, we gave a score, 1 or 2 or 3. This is for the examiner, 1, 2, or 3. Or in MRCOG exams, it's pass, borderline, fail. So there are no numbers. Either we choose pass or borderline or fail. If it's a borderline or fail, we have to write a comment why borderline, and why fail. If it's a pass, we don't need to write any comment about why we gave you pass. Okay. So we have 14 stations, every station 12 minutes, and there are what's called domains. I will talk about them now. Dr. Osama, I had a trial on the last February. Do I have to reset my address again? Just to check your address, Dr. Reem, present on your account today. Okay, check that it's written well, and check that it's same like the country that you want to have the exam in. For example, you are in Saudi Arabia, you want to have exam in Saudi Arabia, check that not your Egyptian address, the one written. Activate your Saudi Arabian address. So what is the meaning of the domains, and what are the types of the exam inside the cubicle? As we said, either you can find a role player. This role player may be playing as if a patient, or this role player may be playing as if he is one of your colleagues. For example, you are ST5 and you are going to talk to ST1 who wants to learn about instrumental delivery. So it's simulated colleague task. The role player will act like a doctor, a junior one. Okay, this role player, is he a doctor? No, at all. That's why please also talk in easy, simple words, because he is not a doctor. The role players, okay, already they are graduated from a school which is training them to be a role player, not doctors. Okay, and this Osler website itself, because I had some discussion with one of the role players in one of the exams, the role player is working for Osler. And this Osler itself was made by the role players. The role players made a very smart idea. They made this website. And then the college gave them money, so the college can use this online program. So they are not doctors. Okay, even if the role player is acting as if he is a colleague, he is not a doctor. So don't say very difficult words. Make it easy, he can understand you well. Okay, so either role player acting as a colleague, or role player acting as a patient, or I find only examiner who will ask me some questions. Of course, the challenge is more in simulated task. The task which contain role player is more challenging. Okay, because here there is the domain of communication with patients. We will talk about the domains now. We have 5 domains. One domain called patient safety, another one communication with patients, communication with colleague, information gathering, and applied knowledge. What are they about? I will start by communication with patients. Very important here, are you talking to the patient in a nice way or aggressive way? Are you empathetic to the patient or not? Okay, are you saying difficult medical terms or not? Don't use jargons with the patient. Jargon means medical term. Don't use jargons. Use simple words. That's why very important to read the patient information leaflets. Okay, so don't use jargons with the role player. Communication with colleague. Are you dealing with him in a friendly way or not? Okay, and are you keen to teach him in a nice way? Are you supportive for him? Are you taking care of him or not? Okay, they are very important. In the same time, they are easy. They come with training. Information gathering, usually about taking history, not any history. We need relevant history. Relevant means related to the problem of the patient. And clinical knowledge. For example, it's a station about diabetes. Did you give right data about diabetes or not? You have good knowledge about diabetes with pregnancy or not? So improving this one will come from improving your knowledge, either from reading guidelines or reading patient information leaflets. From all of them, we will know if you are a safe doctor or not. For example, let's say that the station is about, you are talking to a junior about CTG, and he is giving you CTG chart or CTG paper. And this CTG showed frequent variable diesel with concerning characteristics. You should say that this one is a pathological CTG. What if you said that this CTG is normal one? Mostly, you may take maximum borderline or fail in patient safety. Why? You are not safe doctor. You cannot read CTG. You cannot take pass in patient safety. So what is required? At the first moment, when you enter inside the cubicle, you start at the first moment before speaking, and your grade at this moment is fail in all the domains. You start to speak, okay? Then you move from fail to borderline. You speak more and more, saying right words, using the good technique, and being empathetic to the patient, and saying good data. And it's clear that you are a safe doctor. You reach to take pass in the required domains, inshallah. That's why, while reading the question before entry inside the cubicle, please ask yourself, what are the cubicles what are the domains I need to cover? Because your success comes from covering these domains. For example, if in the exam it's required in this station to cover domain number 2, domain number 3, and the domain number 1. Okay, so information gathering was not asked. I didn't take history, no problem. Information gathering was not required. But take care. Sometimes safety comes from asking specific questions about the history. Okay, for example, a patient has breast mass. There was no information gathering in this station, but I didn't ask if there is any family history of cancer. It will compromise your safety mark. So take care. Safety comes from asking good questions in history and from saying right knowledge without fabricating any data, and comes from your answer to the patient concern and to the patient questions. In the exam, can I say, I don't know? Of course. I don't know is much, much better than saying wrong data, which can compromise your safety mark. So the patient asked me how many milligrams I should receive. I'm sorry, it's not up to my mind at this moment. I will return to my consultant, or I will check in the medicine book, and in the next meeting, or I will contact you to give you the right dose as soon as possible. So don't fabricate data. No problem to say that it's not up to my mind in the current moment. I will check and inform you as soon as possible. No problem at all. No problem. Okay, because this exam is assessing you. And this is the word they say to us before every exam. Before the exam, we always have a meeting with the lead of the exam and his assistant doctors. Always they tell us, we are assessing the candidates at ST5 level. You are not assessed as you are a consultant at all. And please don't answer in this exam as if you are a consultant. You are ST5 in this exam, not consultants. So don't worry much about the knowledge. You passed part 2, mostly your knowledge is enough. You can improve by reading patient information leaflet. And as we said from this slide, before entry inside the cubicle, ask yourself, what are the domains that were required in the question? And how can I cover them? For example, communication with colleague, okay, I will be empathetic to the patient. Okay, I will address the patient concern. I will answer her questions. I will give her ready-made data like patient information leaflet. I will tell her I will give you patient information leaflet. Information gathering. So I need to take the relevant history. I need to ask good questions to take good mark. Okay. Dr. Reem, your question is answered? I answered about your address. Okay, you can keep it as it is, or you can change it to be like one of the countries having center. But unfortunately, we don't know what are the countries that will arrange for the exam so far. Okay, at least Egypt is confirmed. Okay, the exam is covering these 15 knowledge areas. But please, don't bother yourself. This exam covering which area? This question covering which area? Don't care for that. Cover for what are the domains that you are required to cover. Generally, the exam will cover questions about clinical skills. For example, you are going to train ST1 about how to apply forceps. Teaching, the same example. Core skills about taking surgical notes. You may be asked to take a surgical note. Post-operative care, like a patient with vomiting, constipation, distension after operation. Antenatal care, like diabetes, preeclampsia, and others. Maternal medicine, women with chronic disease, like SLE, PKU, and others. Management of labor and delivery. Okay, like counseling the patient about applying forceps in instrumental delivery, or explaining to a junior about what happens during second stage. Okay, postpartum problems like endometritis, infection, postpartum hemorrhage, gynae problems, infections, and abnormal bleeding and others. Subfertility, sexual and reproductive health like contraception and STDs, early pregnancy care like ectopic, mole abnormal bleeding in first trimester, gynae oncology, and urogynae. Don't care much about this question and this station, which area is covered. Don't care for that. Care for the domains that you need to cover, because here there is key of success. From this link, you can download all patient information leaflet, and please start today reading and studying patient information leaflets. Okay, from MRCOG website, you can open patient information leaflets, and you can download them one by one from here. Right-click, download, right-click, download, and so on. Download all of them. They are very easy. Every one of them about 4 to 5 papers. So try to read maximum 8 to 10 patient information leaflets per day. Okay, you will find it's very easy, and it's talking about how to counsel the patient using lay language without using any jargons or any difficult medical terms. Okay, like this one here, or better to download it as PDF, like this one. Okay, in very simple language, how to talk to the patient about recovery with hysterectomy. Another thing also, reading this patient information leaflet, you can be asked about in the exam by another method. They tell you that you need to do critical appraisal to patient information leaflets. What does this mean? They will show you a patient information leaflet, and you need to take your opinion. What are the good and the positive signs in this patient information leaflet? As you see, it should be colorful. It should be in the size of being handheld. It's better to be in the form of questions and answers. As you see, the date is written here, and also who did and who made this patient information leaflet, and what is the date of revision and having a new version for it. Okay, and also adding an email or telephone number if we need to ask any question. Okay, so be familiar with the patient information leaflets. They are very important. Okay. Any questions so far? So we have one example here. It's exactly like sheet of paper you are going to find outside the cubicle that you should read and prepare in 2 minutes. This is a colleague simulated task. So inside the cubicle, I will find 2 persons. One of them, role player, acting as a doctor. Another one is the examiner. So I will enter inside the cubicle after the 2 minutes end. I will enter inside and start directly to communicate with the role player. Don't care for the examiner at all. Even don't say hello, just go to the role player immediately. A doctor asking about patient information leaflet. You can open MRCOG website. Okay, and I will show it to you. This is the main page of MRCOG website. Here for the public, Okay, you can browse all patient information leaflets. If you press this link, it will open the page containing all patient information leaflets. Open them and download them one by one. Okay. It's better to read more than once to be very familiar with it, because the same words you will read, you will talk using them inside the station with the patient. Okay, so here we know that this station will be colleague simulated task. So 2 persons are present inside. One of them, the role player, who is acting like a colleague. The other one is the examiner. I will not care for the examiner at all, except in structured discussion. In a structured discussion, you will say, hello, sir, and I am ready. Don't say your name, please. Don't say your name. Okay, so it's colleague simulated task. I have these 4 domains should be covered in this station. We have to memorize the 5 domains: communication, patient, colleague, applied knowledge, the very important one, safety, and the last one, to communication, knowledge, safety, and information gathering. Okay, so here now I know that this station will examine me in 4 domains. Communication with colleague. Okay, so I will be very friendly. I will be supportive to this junior. I will encourage him to ask me questions. I will even prepare that we can have further meetings about any other topic he wants to talk about later. In the same time, I will not be judgmental. Even if he did mistakes, I will be friendly. Now I prepared myself for this domain. Okay, information gathering, patient safety, applied knowledge. You are going to meet your colleague Osama, who is ST1. He wants to know about shoulder dystocia. Okay, so communication with colleague, I will be supportive. I will ask him if everything okay in the hospital, if everybody is supportive to him, if there are any problems, and very important to appear supportive and friendly. And please give the junior very big smile. Hello, I am Muhammad, ST5 and you. I am Osama, ST1. Hello, Osama, welcome. Hello, Muhammad. Okay, be very friendly. Information gathering. Like what? Osama, I know that you want that we discuss today about shoulder dystocia. Can you tell me what you know about shoulder dystocia and why you choose this topic specifically? Because there may be something, there may be a scenario that he wants to discuss. Okay, in patient safety. In shoulder dystocia, I will not forget to say call for help. I will not forget to mention the algorithm of shoulder dystocia management. I will not forget to tell OSAMA that shoulder dystocia increases the risk of postpartum hemorrhage. So you need to examine well the birth canal after delivery. Okay. And I will not forget to say that we need to write incident report after that. Okay. And applied knowledge. So I will revise in my mind rapidly. The algorithm, the first step was call for help. Then there was the position, it was MAC Robert plus or minus suprapubic pressure. So assistant will help me. So I prepared the knowledge needed for this station. Okay, so in the 2 minutes, I read the scenario. I prepared myself how I will cover these domains. Clear this point? Okay. Who wants to practice? I need a volunteer. This volunteer, he will act like the candidate, and I will be the junior ST1. Somebody wants to act? Please, please, please. This exam needs active participation.
Ma'am, sir, shall I, sir?
Yes, this is Dr. Manikam. Welcome.
Yes, yes, sir.
You are planning for part 3 exam, doctor, right?
Yes, sir.
Okay. When you passed the part 2?
In the last September, sir, 2021.
Congratulations.
Thank you, sir.
This will be your first trial?
Yes, sir.
Okay. Our best wishes for you.
Thank you, sir.
Noted that the station will be against the time. So here is the clock. And the clock is adjusted to 12 minutes. You can see it well, right?
Yes, sir.
Okay. I will start the timer. You have 2 minutes to prepare.
Yes.
When the timer becomes 10, you have to start.
Hello, Osama. How are you?
Yes, hello. Hello, I am Osama ST1.
Okay. I am ST5. How do you find the postings here? How do you find the people around?
It's interesting.
Good to hear. If you have any problem, if you have any difficulty, you can come to us. We seniors are here to help you.
Yes, it's okay so far.
Osama, I came to know that you were so very much interested in about learning about shoulder dystocia. How come you developed this interest?
Actually, I see in the labor ward within few days a case of shoulder dystocia, but I didn't understand what they are doing. I found people shouting, everybody coming to the ward. I didn't understand what they are doing in these steps. So if you
Hi.
don't mind, I need to know more.
Your concern is valid, and we will learn together. So, shall I start now?
Yes, please.
You can stop me at any time if I am not clear. This shoulder dystocia is an obstetric emergency in women with high body mass index and women with a bigger baby and women with diabetes. Even if it is gestational diabetes, we should in women with prolonged first stage and second stage of labor, we can should have been. We could expect. We should be anticipating this shoulder dystocia. So everybody should be alert. And do you know how to diagnose this condition?
No.
Am I clear so far?
Yes, clear.
Can you repeat one indication, the risk factor?
Preeclampsia?
I don't know about preeclampsia. Women with bigger baby and diabetes, they are more prone for.
Okay.
Preeclampsia may not be prone because they may have the smaller baby, I think. Women with the macrosomia baby, they are more prone for this condition. So next we'll go for the diagnosis of this condition. In this condition, the head will be delivered, but it will not go for restitution. It will be difficult for the head to restitute because of the bigger shoulder. Am I clear?
Yes, it's clear.
So the shoulder will, the baby's head will be retracting behind into the pelvis, into the vagina. That we call as turtle sign. The restitution is not happening. So this is actually a bony obstruction. Mostly the anterior shoulder gets stuck. And there should be, if we diagnose this, we should confirm the diagnosis by gently giving mild traction in the axial direction. If you do that, if it is not coming, then we can confirm. Then once we diagnose, we should call for help as it is an emergency. So a scriber will be there. She will be recording all every event and all. Should call for help means the trained specialist midwives, consultant, the anesthetist, and the pediatrician, everybody will be around. We have to inform the OT also. If it is not going to be successful, we have to shift the patient to OT. Am I clear so far?
Yeah, clear. Thank you.
So what we should ask the mother not to push. Then if she's on any oxytocin, we should stop it. And if any of our midwives on the head side, trying to give fundal pressure, we should ask them not to push, not stop the fundal pressure. And then we should explain to the woman in a detailed manner. And then we are going to do some maneuvers to help you to deliver the baby. Like that, we should explain to her. And after getting verbal consent, we should bring the woman to the edge of the table. And we should confirm whether she's under anesthesia. If it is epidural, that will be better. Am I clear?
Yes.
This epidural is good for the upcoming so many techniques are there. You should have seen already, but I'm telling you in detail. So now with the two specialist midwives, we should do first procedure is called MRCOG maneuver. That is, we have to bend the thighs of the mother over the abdomen, external rotation, and abduction. This is called McRoberts maneuver. Can you repeat?
Yes. So McRobert, we separate the legs away and towards her abdomen.
Good.
Okay.
Good. You're a fast learner.
Thank you.
It leads to 90% of success. So every procedure to be continued only for 5 seconds. And one scriber will be recording this. So if after 5 seconds of this procedure, you have to give mild axial traction and see whether the shoulder has come down. This procedure will open up the anteroposterior diameter of the pelvis. Am I clear so far?
Yeah.
Then if it is not successful, then we go to the next step. That is the suprapubic pressure. One assistant standing on the side of the mother's abdomen, on the side of the baby's back shoulder. So she will be giving pressure over the back of the anterior shoulder downwards and towards the posteriorly. She'll be pushing the shoulder down in a jerky manner or in a continuous pressure. She'll be giving this so that the shoulder, anterior shoulder, slips under the symphysis pubis. This will be continued for 5 seconds. So this is a suprapubic pressure. Both will be done together. MRCOG and suprapubic. Am I clear so far?
Yeah.
Then even if this is not successful, what happens? We should assess for the episiotomy. Episiotomy is not to overcome any obstruction, as there is no soft tissue obstruction. We have to use the hands for internal maneuver. For that, we need some space. So we do this episiotomy. As usually, it will be given the, do you want me to explain about a mediolateral 60-degree episiotomy?
No.
You're already, you know very well. So after doing this, the internal maneuvers will be done. The hand with the glove will be put anterior to the baby and pushing the anterior shoulder from behind to internally rotate it. Similarly, the hand on the posterior aspect of the baby, towards the sacrum, no? So we'll be pushing the posterior shoulder also from behind so that it is also getting internally rotated so that the baby will occupy the oblique bigger diameter of the pelvis. This will reduce the bisacromial diameter of the baby. So that the anterior shoulder can slip from the under the symphysis pubis. So this is called as internal maneuvers. Am I clear?
Yes.
So first we had the MRCOG, second suprapubic. Next is the internal maneuvers. Even if this is not helping, we can go for the removal of the posterior arm. This can be done by searching for the posterior arm, forearm and hand. Then we have to sweep the forearm over the front of the chest of the baby so that the shoulder will come underneath the pubic symphysis. So even if everything fails, what to do? If the woman is thin and not an epidural, then she can be put into all-four position. Otherwise, by this time the consultant should have arrived and she will be repeating all the procedures again once more. If everything fails, if you say this all-four position helps in 83%, it becomes successful. And even if this fails, the last resort is the consultant may do an internal fracture of the clavicle sometimes, or syncytiotomy she may do, or else she will push the head into the vagina and the patient will be shifted to the theater. This condition is called as Zavanelli's maneuver. This is indicated only in rarely in anterior and posterior shoulder being, that is dislocated. Anterior and posterior shoulder getting stuck, or both the posterior shoulder dystocia is there. Am I clear so far?
Yeah.
Then after the baby is delivered, whatever way we follow, the baby is handed over to the neonatal resuscitation team. They will be taking the blood gas analysis and the serum lactate, everything. They'll be looking for any injury. And we have to monitor. We have to make out that. Sir, the time is over, sir.
Time is up.
Oh, sorry, sir. Okay, sir. Thank you, sir.
No problem. Thank you. At first, I want to ask you. I think you had much training before your performance actually was good. But I want to hear from you first. What is your feedback? What went well and what you can improve? What do you think? What went well?
I have to ask you to repeat, but I was rushing, sir.
You did already. you asked me one question and I answered it,
Yes,
and
sir.
I intended to answer it wrong to see what you will, what you,
Yes, sir. Yes, sir. Well, I
if I
only, and then
answered
I
the wrong
corrected.
answer. Yes.
I didn't discourage you. I said it
Excellent.
is good, like that I was doing. I have
Excellent.
to shorten my duration, sir. I have to train so much. Thank you for
Thank you.
the so great mentor under whom
Thank
I
you.
have presented once. I'm really very, very proud this day, sir. I'm really blessed to present in front of you.
Thank you.
I mean,
Welcome.
I'm not able to express in words, sir. So many
Welcome
thanks,
always.
sir.
Thank you very much. You are welcome.
I
Much
feel
welcome.
blessed. Thank you, sir.
Thank you. And let me add some points to this feedback. I liked much your language. It's easy language, and I liked much your self-confidence. You are not hesitated. You are not afraid. No, I liked much your attitude.
Thank
It
you,
will
sir.
give a good impression to the examiner that you are a self-confident doctor. And self-confidence gives very good image to the examiner. Because some doctors, even if he has good knowledge and he is practicing well, but hesitated, okay, and very irritable, it will give bad impression. Okay, and if at certain point the examiner is query between pass or borderline, because of this hesitancy, he will prefer borderline than pass. Okay, but it was very good language and very good self-language. Okay. Let's start by the things you did very well. Okay, I like that you asked why you want that we talk about this topic specifically. Okay, and no need to say why you want me to teach me, why you want me to teach you about this topic. Why you want that we discuss or talk about this topic. Don't make it teaching and learning. Okay. And I like that you said the definition. Okay, it's a delay about 60 seconds between delivery of the head and delivery of shoulders, and it will give turtle sign, exactly as you said. Okay, it was excellent when you said the first thing you should do is call for help. Okay, also you discussed at first the risk factors. Okay, you talked about turtle sign and that the problem is a bony problem, not soft tissue problem. Okay, and you explained well the algorithm of shoulder dystocia. What do you can improve? You forgot to say your name at the beginning, right? So you have to say, hello, I am Manika, for example, 85.
Yes.
Okay, 85. Okay,
Sir,
so
I
you
was so much overwhelmed, sir.
no problem.
You're my ideal mentor from part 2, sir. I have attended so many of your meetings. So I became so nervous that I forgot mentioning my name.
Okay, but
I
in the
never
exam,
thought of presenting in front of you.
welcome.
Still, I'm not able to believe, sir.
Welcome, my dear friend and my dear sister. Okay, don't forget in the exam to say your name to the role player. Don't say your name to the examiner in the structured discussion, but say your name to the role player, whatever, colleague or a patient. Okay, and you were very supportive to him, asking is everything okay, any problem in the department, everybody is supportive, and also you encourage him to ask questions. And you said at least 2 times throughout all the station, am I clear so far? It's very important. And you did that. It was excellent. And I recommend when you ask the junior a question, don't ask him about something you didn't say. For example, Osama, do you know about the risk factors? You didn't explain them yet. As I told you, the role player is not a doctor. Okay, he is just a role player. He didn't study medicine before. Okay. That's why if you ask him about something you didn't say, he will say, I don't know. You missed some time for no benefits. But exactly as you said, explain something, for example, the risk factors, and tell him, Osama, can you tell me one of the risk factors, please? One, not all the risk factors. Okay, ask about one so you can save some time. Okay. And Your knowledge about the topic was very good. Okay, the examiner in a station about shoulder dystocia, he will like to hear from you the word that there is a mnemonic called helper.
Yes, sir. I know, sir.
Do
I
you
will
like?
tell, sir. Next time I'll tell. I
Excellent.
know that. Hmm.
Do you like to hear it? That
Hmm.
Osama, did you hear before about a mnemonic called helper? Okay, in one of the previous exams, the station was about CTG, and the candidate asked the role player, did you hear before about Dr. C. Bravado?
See the wala.
The role player said, is he one of the doctors with us here in the department? Okay,
Yes.
he doesn't know what is Dr. C. Bravado. Okay, so saying helper here would be very good one. So what is helper? It's number one. You need to call for help at the beginning, okay? And you will need to assess for episiotomy before
Yes.
doing any internal maneuver. L, leg of the patient that you will do Mac Robert, okay? And the pressure, suprapubic pressure. E, enter your
Enter.
hand to do the rotational maneuver. R, removal or delivery of posterior arm. Then R, all four position.
Sir, I am repeating from your teaching only, sir. I remember everything.
Excellent. At the beginning, if everything failed, you will apply all four position and repeat again the steps from the beginning. Okay, this station, try to save time, try to finish as fast as possible, because there are very important things after shoulder dystocia, like examining the vagina to exclude postpartum hemorrhage, active management of third stage, and don't forget delivery of placenta. So we need active management of third stage, writing instant reports,
Yes, sir.
talking to the patient. The patient doesn't know what happened. So we need to do debrief. Debrief means talking to the patient after the event. Okay, I understand much that the scene was very terrifying to you. You saw many people running and shouting. Let me explain. What happened is that so and so. What we did, so and so. The possible complications, so and so. And how this can affect the coming pregnancies, so and so. Because there is risk of recurrence tenfold, as you know. And there is risk of postpartum hemorrhage. That's why, Osama, we should ask about the patient if she has any concern about blood transfusion. And if there are any contusions, any trauma, we may need to take stitches under anesthesia in the theater. Okay? And always, Dr. Manika,
Yes, sir.
can I say Manika or?
Yes, sir.
Okay.
Call me Manikam, sir.
Moni?
Manikam. Anyway,
Manikam.
sir.
Okay. Okay, Dr. Manikam. So always check the domains. Communication with colleague, yes, I was supportive. I talked to him in a simple language. I encourage asking questions. And I asked him about the environment in the hospital, everything okay, any problems? Because sometimes there can be a twist in the scenario that we are going to discuss shoulder dystocia, but this is not the main target of the station. The main target that this doctor was subjected to bullying and undermining from another person in the department. So at the beginning of the station, you will find the doctor or the role player is avoiding eye-to-eye contact. And he is feeling sad. So there is twist in the scenario. Because shoulder dystocia here is not the main target. That's why it was excellent from you that you asked why you want this topic specifically and is everything okay in the department and if everybody is supportive to you. Okay, thanks much, Dr. Manika.
Thank you, sir.
Dr. Monica.
Thank you,
Thank
sir.
you. So let's see
Thank you,
what
sir.
I wrote here in the model answer. At first, introduce yourself. Okay, nice to meet you. And give a big smile. Okay, if you appear as supportive and very familiar with the role player, it will be very good. Always imagine that the patient is like a customer. We need the customer to be happy. Okay, okay. For how long you have been here with us? Everything okay? Everybody supportive? I understand that we are here today going to discuss shoulder dystocia. Am I right? Can I ask you why you want this topic specifically? Okay, to put an agenda, we'll talk about risk factors, how to manage. Then we'll talk about the care after delivery. And Osama, by the end, I will give you some important links about some good videos on YouTube to show you well about the management. And if you want, we can plan further meetings to discuss any further topic you want. So you are very supportive to him in his learning process. So start by the definition and say turtle sign that there is delay 60 seconds between the head and shoulders. And it's a bony problem, exactly as you said. And Osama, we have a mnemonic called helper. Did you hear about it? Then explain what is helper. Start at first, call for help, ask the patient not to push, and you don't pull because it's bony, not soft tissue problem. Suprapubic pressure with or without, a MRCOG with or without suprapubic pressure. If failed, I will do internal maneuver. So here, Osama, it should be, we need at first to assess for episiotomy. And this internal maneuver should be under anesthesia. So if there is epidural, I can ask the anesthetist to give a top-up extra dose because I will do internal maneuver, which are painful. Either delivery posterior arm or internal rotational maneuver. Whatever rotation of the anterior shoulder or posterior shoulder or both. If everything finished, all four position. Failed the invasive maneuver, like fracture clavicle or to return the baby inside and delivery by cesarean section, which is called the Vanelli, or to cut symphysis pubis. After delivery, the baby will be seen by a neonatologist. The neonatologist will do a bird cord blood sample to exclude any hypoxia. Okay, and will apply upper score to the baby and any resuscitation needed. For the patient, after delivery of the baby, I will examine the birth canal. I will do active management of third stage. Okay, and after that, I will debrief to the patient using the duty of candor to talk frankly to the patient, not hiding any data, and telling also here what can be the outcome after that and what can be the outcome in the next pregnancies, because there is a risk of recurrence. And don't forget, we will sign and fill an instant report. Okay, here's some data about shoulder dystocia, its incidence, and 60-second turtle sign, and the risk of brachial plexus injury. So we need to examine the baby because there can be Erb's palsy after delivery. 90% it's reversible and recoverable. 10% it can be permanent injury. Also, in talking about shoulder dystocia, it will be good to say, although there are risk factors, but to a large degree, it's unpredictable. Because even without risk factors, it can happen. Here, examples about risk factors: macrosomia, diabetes, high BMI, and so on. And how to prevent, not important to be said. This is for your knowledge. And this is what is helper: call for help, episiotomy, leg MRCOG, pressure suprapubic, enter your hand to do rotational maneuver, remove the posterior arm, and roll over to all four position and repeat again the procedure. And here some photos. It will be fine if you tell the role player. I will give you some useful YouTube links about how we can manage shoulder dystocia. And I think from part 2, you know about what's called PROMPT. Okay, PROMPT is multi-professional training. They do very, very good videos on YouTube. It's a British society called PROMPT. Okay, you can find very, very useful videos about management of shoulder dystocia, applying instrumental delivery, and others. Okay, MRCOG, efficacy 90%, all 483. And after that, exclude postpartum hemorrhage, repair any tear, okay, and exclude any complication to the mother and to the baby, and fill the report about shoulder dystocia, including here in this part, this drawing about which shoulder was the anterior one. As obstetricians, we can do herpes palsy to the anterior shoulder, not the posterior shoulder. It's important medico-legal. So if this is the baby and the baby facing to this side, so this shoulder, which one of the baby? Can you say? This shoulder, the anterior one, is the right or the left? This one is the right one. It's the right shoulder. Okay, and look here on this another drawing. This is the face of the baby. The baby looking this side. The baby looking this side. So this anterior shoulder is the right one or the left one? It's the left one.
Left one.
Okay, so if there was injury to the left plexus and the baby was in this position in labor, so it's iatrogenic. But if the right plexus, mostly it's not iatrogenic. So this form is very important because it may save us medico-legally if there is herpes palsy to the left shoulder, not the right one. We don't injure the posterior one. We injure the anterior one, not the posterior one. Am I clear so far? Any questions? Give some useful links. And ask also, how was our meeting? Can you tell me, Osama, please, how can I improve it? Try to say the name of the role player multiple times. Whatever the role player is a patient or a colleague, saying the name of the role player multiple times, okay, it will indicate that you are a friendly doctor. Okay, any question? Thanks much, Dr. Manikam. Thank you.
Thank you, sir.
You did very well. Any question? Any question? Okay, very few words about my preparation group, how we can prepare for November exam. Okay, I have a course. The course is composed of 12 sessions. In every session, we discuss 10 stations. Okay, there are active candidates. Maximum number of active candidates is 10. So every one of them will have one active station every meeting. You will know before the meeting as an active member which station you are going to prepare. So you prepare for it very well. So you will perform it same like Dr. Monikam done today, okay, in front of all the audience. Then I will give you feedback. Also, there is another package called the listener that you will attend with us all the meetings and study from the material, including the PowerPoint and the videos on my website. There is another very, very, very limited package called one-to-one that I will have a meeting with only one doctor in these private sessions. Okay, so you will practice alone, not in front of audience. So you can have feedback specific and tailored on your practice. Okay, here on my website, you can find the material of part 3 preparation. Okay, it's including the videos and PowerPoints of all the coming meetings of the course. So it's covering, as we said, 100 stations. Inshallah, most of the exam will be coming from these 100 stations, most of it. You can find only 1 or 2 stations which can be strange or having a new idea. But don't worry, already you know the templates, you can cover it upon anything. Okay, here some feedbacks from previous course members, whatever part 1, 2, or 3 that I am very proud of. Okay, also there will be WhatsApp group. So if you want to ask, we will be available. And even doctors who will not join the course, okay, I am exact like your brother. You can ask me if you want about anything. Okay, so we have 12 meetings, small number groups. There is active, listener, and there's also one-to-one. It's recently introduced. Okay, and we meet every Sunday, 4:30 p.m. UK time, same like today meeting. Today meeting, I recorded it. already. And if you want the recording, just send me a message on WhatsApp. And already I will put the link for the recording of today on YouTube. I will put it on WhatsApp group within few hours, inshallah. How much time is enough for preparation? If you are a recently doctor who passed the Part 2 exam, so you have good knowledge, I recommend you start preparation directly to Part 3 and join November exam. Why? If you wait more, you will forget and your knowledge will decrease. What if you didn't study since long time? Study first. You can have preparation, for example, few months, reading guidelines, improving again your knowledge, then start preparation for the exam. But doctors who passed recently in Part 2 exam, all what you need, patient information leaflet to know the lay language of the patient. 2.5 months enough for November exam. It depends upon your time. If you are a very busy doctor, you can save only 1 or 2 hours per day. It's not enough. So delay the exam. But if you can save that you can practice 10 stations per day. So I am talking about at least 3 to 4 hours per day. Delay the exam. Don't join November exam. Recently means passed through September or not September, passed through July exam. July exam. 4 hours daily, yes, they are enough. In these 4 hours, you can practice more than 10 stations and read multiple patient information leaflets. 4 hours per day, yes, it's very good. Notice that this exam, it's better and it will be very difficult if you try to study alone. There should be a study partner that you meet daily and you practice in front of him and he gave you feedback. It's very, very important. Okay? You cannot study for this exam alone. It must be in a group made of at least 2 doctors, you and one else. I am talking about 2022. Doctors who passed the last week. I recommend that they join November exam. Okay? Doctor who passed in January, also the knowledge is still fresh in their minds. They can join November exam. But doctors who passed 1 year ago or more, if they were studying and they studied the guidelines recently, okay, go to November directly. Doctors who were away from studying for a long time, I recommend at first that you start reading the guidelines, improve your knowledge first. Okay? Any question? The timer is still working. How we can practice 10 station daily and we don't have the station. Okay, doctors who are present in the course, already they have library made of 100 stations with their answers. Otherwise, you can get stations from books. There are books for Part 3 exams. They contain many stations. Okay? Or even of the recalls. You can study them. They are very important. Clear? Okay. Thank you. We finished. I mean, we will apply afterwards with you. So we'll have an access, of course. Once you apply, you will have access to the full library, including the recordings of the last course, containing more than 100 stations with their model answer and their video. And in the meetings, inshallah, all audience will be asked to give a feedback to the doctor who participated in front of them. If you imagine that you are an examiner and you start to do assessment of others, you will pass, inshallah. Because now you know what the examiner is looking at. What is he searching for? Okay, so we finished today, alhamdulillah. I will be happy to receive your questions on WhatsApp, inshallah, at any time. And the best wishes for you all, inshallah, and see you soon in the ceremony in London, inshallah. Doctors who will pass in November exam, they will be present in London in February to attend the ceremony and receive their certificates, inshallah. The next meeting in this course will be next Sunday in the same meeting, in the same timing like today, inshallah. Okay, thanks much for all of you. See you soon and best wishes everybody. Thank you. Assalamu alaikum. Goodbye.